data, because there is a lot of, it have been a lot of expectations now also for the renal data, because many of these cardiovascular trials have shown very positive findings. And that's the reason why, of course, we were waiting for the data also from the Vertige CV trial. Let me, before I go through the results, let me tell you a little bit about the renal composite, because you can see from this slide that the renal composite consists of renal death, dialysis, transplantation, or doubling or serum creatinine. Doubling or serum creatinine is a very, very strong and hard endpoint. And it basically means a 57% reduction in eGFR, not a 50%, a 57%. So this is an extremely hard. Renal death means that the patient should be on dialysis but refuses. So very few patients in any of these cardiovascular trials actually have achieved that endpoint. So it's very much up to the doubling of serum creatinine. And then you can see, if you look at the number of patients that had renal death, 0 in placebo and empagliflozin group, the same, very small numbers for the renal replacement therapy, but doubling of serum creatinine is the largest point. So this is, I reiterate myself, but this is a very hard endpoint. Now, if you look at the data, the curves look very similar to what we saw in the EMPA-REG outcome trial, which was the first one to show data on the renal composite endpoint that also had a doubling of the serum creatinine. So in the beginning, the lines were superimposable, but after that, you saw a difference. And however, according to the hierarchical testing, that could not be statistically tested for superiority, because the cardiovascular or heart failure was not achieved. But you can see here a p-value of 0.08 and hazard ratio 0.81. So these data go in the same direction as previous cardiovascular trials, and that is, of course, good news. Next slide, please. If you then look at the eGFR over time, what we can see, and we have already seen that in previous cardiovascular trials, that you will see an initial drop in the eGFR. After that, what you have seen before, and you can see also in the Vertige CV, is that you will see a preservation of the kidney function, which is not seen in the placebo, because in the placebo, what you see is a steady decrease in the eGFR, and that is something that we have seen so many times before. But with empagliflozin 5 or 50 milligram, you can see a preservation of renal function over time, and it's about 3 ml per minute per year. Next slide, please. If we then compare the Vertige CV renal data with the previous ones, the EMPA-REG outcome, the CANVAS program, the DECLARE TIMI, let me come back to the composite endpoint. Now you can see that the CANVAS program and the DECLARE TIMI, they had a different composite endpoint. They looked at a sustained 40% reduction in eGFR. That is not as hard endpoint as the doubling or serum creatinine, which is equals to 57% reduction. So that's a big difference. And so Vertige CV is much, much more similar to the EMPA-REG. Now, the data go in the right direction also for the Vertige CV, although this trial did not meet the statistical significance as the other ones. But again, the good news is that they go in the same direction. Next slide, please. And if we then also include the Credence trial, which was not a cardiovascular trial, it was a dedicated renal trial. And we put Vertige CV on top of the others and do a meta-analysis in terms of the time to the first renal composite endpoint. What you can see here is that all of them basically are left on the unity line. And these are good news for the SGLT2 inhibitors, because it means that they all seem to preserve kidney function. And also, if you look at the renal composite endpoint, you seem to be on the left of the unity line. It means that you may prevent a composite renal endpoint. And the pooled estimate here is 0.62, and that is very good news. So although it did not reach the statistical significant level here, the data are consistent with other SGLT2 trials, and that is, of course, what we wanted to see from these data. So that's the renal data, and I'm happy to hand over now to Sam.
Thank you, Perra, for that exquisite discussion of the renal endpoints and very reassuring final conclusions. It's my pleasure now to talk about the adverse events. And as can be seen, urinary tract infection did increase, but it was actually high at the background. And when you compare placebo to ersodetropine, the relative differences were modest, 10.2% in placebo versus 12% in the drug treatment groups. Genital myocardic infection in men and women was significant, well, numerically higher as expected, approximately 4 to 5% in the drug group versus 1 to 2% in the placebo group. Hypoglycemia was uncommon and not different across placebo and drug groups. And hypovolemia-related events, namely orthostatic symptoms, were again approximately at 4% across all three comparison groups. We saw very few cases of pancreatitis that was adjudicated, and the event rate was too small for meaningful comparisons, either acute or chronic. Next slide. We looked at adverse events of special interest, including acute kidney injury, which reassuringly was not increased in the drug-treated group, actually slightly lower in the ersodetropine group than placebo. Amputation rates were 1.6% in the placebo group, 2% in ER2 5 milligrams, and 2.1% in ersodetropine 15 milligrams. Diabetic ketoacidosis frequency ranged from 0.1% to 0.3 and 0.4, again very low. We noticed adjudicated fracture occurring in 3.6% in the placebo group, 3.6% in the ersodetropine 5 milligram group, and 3.7% in the ersodetropine 15 milligram group. Reassuringly, we didn't observe a single case of Fournier's gangrene. Next slide. So to put it all together, the Virtus CV trial is actually consistent with what is known for the class, and along with the meta-analysis results, we can confidently say that there is a modest effect in reducing MACE outcomes across the class, with EMPA-REG outcomes significant due largely to the reduction in cardiovascular death, but no specific effect on components of MACE such as MI or stroke. CANVAS study was significant on MACE, largely driven by contribution from decreases in MI, CV death, and stroke. And DECLARE and Virtus found trends on MACE. When you look at CV death, there was one major outlier, the EMPA-REG outcome trials that demonstrated significant risk reduction for mortality, which drove vast heterogeneity when you compare other members in the class. In contrast, the hospitalization for heart failure measure was consistent across the class with approximately 30% risk reduction, and the benefits were independent of baseline status regarding prior heart failure or abundance of atherosclerotic cardiovascular disease. And these effects occurring across the spectrum of enrollment eGFR levels proves extremely robust and reassuring. Next. The renal outcomes, as you just heard from Dr. Group, again show benefit, with Virtus CV only showing a trend, in part due to the definition of the composite renal outcome. We observed that the Virtus CV showed kidney-related outcomes that were generally consistent with other members of the SGLT2 class, and the effects on acute and chronic eGFR changes were also consistent with the class, and renal adverse events similarly were in line with other members of the class. So there were no untoward signals of renal-related adverse events. Instead, there was a consistent trend of benefits compared with other members of the SGLT2 class. Next. So in summary, the VIRTUE-CV achieved its primary endpoint of demonstrating safety and non-inferiority to placebo. It provides further evidence of cardiovascular safety and for the class, which is very reassuring. And the data we observed in the VIRTUE-CV study do not alter estimates of risk for any specific safety signals. And the meta-analysis output strongly support the contemporary societal priority recommending the use of SGLT2 inhibitors independent of glycemic control in patients with type 2 diabetes who already have or are at risk for cardiovascular and renal complications. Thank you.
Terrific. Well, thank you very much, both of you, and exciting to see new data. I think now the questions sort of become, well, how do we use these data in practice? And you know, my sense of the recent year or two of data is that it all focuses on the kidney. That, you know, there are just big effects in the kidney, and that likely impacts on heart failure. And you know, what is your sense of the nephrology view of is this really people finally seeing how the kidney can benefit all these cardiovascular outcomes?
So, Chris, thank you for that question. I'm the nephrologist, so I tend to look at everything in medicine through the kidneys, but there is a reason for it because, as you know, the kidneys and the heart, they really work together. And as you all know, that a lot of the drugs that we are using to treat heart failure, actually they work through the kidneys. And that is exactly what happens with the SGLT2 inhibitors, because the SGLT2 inhibitors, by blocking the renal, the reabsorption of sodium in the proximal tubule. Actually, sodium reaches the macula densa, you generate adenosine, and you close the afferent arteriole. So you actually ease the burden of what hyperfiltration and an increased renal blood flow causes in the kidneys. And what they usually cause is kidney hypoxia, because in any situation where you have an increased renal blood flow, you have hyperfiltration, and whenever you have hyperfiltration, you push the sodium handling in the proximal tubule. And 90% of the oxygen consumption in the kidneys are actually due to sodium handling in the proximal tubule. So if you have a situation like obesity, hypertension, or diabetes, where you have hyperfiltration and increased renal blood flow, you push the sodium handling, you cause hypoxia, and that causes kidney damage. And if you ease that by blocking with an SGLT2 inhibitor, you not only ease the burden on the kidney, but of course, secondarily also on the heart. So I think this is a wonderful example that all members, what we have tested so far in the class, seem to work in the same direction. They have effects on the kidneys, and we see also effects on the heart.
You know, it is exciting because usually the interaction of the heart and the kidney is that we over-diurese patients, the kidney goes up, we start cursing the kidney saying, you know, but here all the benefit is really coming from there. Well, Sam, I think you beautifully also showed effects on blood pressure, you know, and body weight and improving glycemic control, all the sort of the risk factors. But all that's important too, I think, in the approach towards a patient who has disease issues. How do you see this as fitting into overall risk factor control?
Oh, yes. That is very consistent with the class and supportive of the current clinical enthusiasm to deploy SGLT2 inhibitors among the therapeutic armamentarium for controlling glycemia in people with type 2 diabetes. As you know, Chris, the vast majority of our type 2 diabetic patients are overweight or obese. And the consistent induction of weight loss from this class is very welcome by our patients, as is the modest effect on blood pressure. And then if you, along with that, take the nearly 1% decrease in HbA1c, you have a beneficial triple whammy on weight, blood pressure, and glycemia. And when you look at the cardiovascular outcomes trials across the members of the class, the point estimate is never above 1, always below 1. The confidence intervals, which is a statistical expression of heterogeneity, may lie where they eventually landed. However, the fact that the consistent point estimate is below 1 also, I think, speaks beneficially for the class. These studies were conducted largely to prove cardiovascular safety, and it was quite a pleasant surprise when members of our profession observed glycemic or extra glycemic benefits in terms of kidney and cardiovascular outcomes. So again, I remain very confident of the value of the class of drugs in the overall treatment approach to type 2 diabetes.
Well, it's terrific. And I think as you concluded, the findings that we review here and then indeed in the meta-analysis are really supportive of our new guidelines, from the ADA and EASD and the ESC, all the guidelines are really focusing on the importance of this class of drugs in improving cardiovascular and renal outcomes and then these other metabolic effects. So I think it's exciting to have yet more evidence supporting it, and it does shift our focus to trying to implement these guidelines. And so hopefully with fresh new data, and there'll be more details at this Congress. Indeed, on Monday, there'll be a detailed presentation of the heart failure results and subgroups and total events, and that we can really focus on trying to implement our new guidelines. So with that, I'd like to thank you both for wonderful presentations, and thank you, the audience, for joining us.
Thank you.
Thank you.
Dear ladies and gentlemen, dear colleagues and friends from around the world, welcome to the second hotline presentations live from the studios of ESC Congress 2020 in Amsterdam. I'm Stefan Achenbach, and with me in the studio are Silvia Priori and Franco Cecchi. And I'm really happy to be here because we're going to hear the results of the Explorer-HCM trial, which is particularly exciting because it looks at an entirely new class of drugs in a disease that is very relevant for us cardiologists. Silvia.
Thank you very much, Stefan. So without further ado, we can connect with the presentation by Professor Olivotto and know the result of this exciting trial.
Ladies and gentlemen, on behalf of the co-investigators in this trial, I want to thank the European Society of Cardiology for the opportunity to present the results of the Explorer-HCM study. From this study, a new molecule has emerged with a promise for targeted medical therapy of obstructive hypertrophic cardiomyopathy for the first time since the original description of the disease almost 60 years ago. These are my disclosures. The study was sponsored by MyoKardia, for which I serve as a consultant and a member of the steering committee. Hypertrophic cardiomyopathy is a myocardial disease characterized by genetically driven and otherwise unexplained left ventricular hypertrophy. But the core pathophysiologic features of the disease include hypercontractility, diastolic abnormalities, and dynamic LVOT, left ventricular outflow obstruction. Current treatment for obstructive hypertrophic cardiomyopathy focuses on symptomatic relief using old drugs such as beta blockers, non-dehydropyridinic calcium channel blockers, and disopyramide. These are old drugs which were not designed to address the molecular defects of hypertrophic cardiomyopathy. They do not modify the natural history of the disease, and for many patients, these options are insufficient to adequately resolve the symptoms and or may have side effects. There are, of course, invasive options for obstructive hypertrophic cardiomyopathy, such as septal myectomy or alcohol septal ablation, which are more effective, but they obviously have inherent operative risks and are the expertise required to perform these operations is not universally available. Therefore, developing effective pharmacological therapies for obstructive hypertrophic cardiomyopathy represents a major unmet medical need in cardiovascular medicine. In hypertrophic cardiomyopathy, too many cross bridges between the thick and the thin filament lead to excess contractility and impair relaxation. Therefore, mavacamten was developed as a first-in-class small molecule selective allosteric inhibitor of cardiac myosin ATPase. And by targeting the underlying pathophysiology of hypertrophic cardiomyopathy and reducing active myosin cross-bridge formation, this drug improves contractility, excess contractility, and restores myocardial energetics. Following very positive phase 2 data, the Explorer-HCM trial was designed as a pivotal phase 3 randomized double-blind trial in patients with symptomatic obstructive HCM, and the protocol has been previously published. Adults with left ventricular outflow gradients greater than 50 millimeters of mercury and symptoms comparable to NYHA class 2 or 3 were randomized to receive mavacamten or placebo for 30 weeks. Patients began on 5 millimeters daily with titrations at weeks 8 and 14. They were allowed to continue on their background therapy with beta blockers or calcium antagonists, although disopyramide was not allowed. The study endpoints were designed in collaboration with disease state experts, patients, and the FDA in order to capture changes in outcomes that are hallmark and relevant to HCM. The primary endpoint is a composite assessing clinical response as both function and symptoms at week 30 compared with baseline, and is defined as achieving either at least a 1.5 milliliter per kilo per minute improvement in peak VO2 response on cardiopulmonary testing, and at least one NYHA class reduction, so improvement in symptoms, or a greater improvement in peak VO2, at least a 3 millimeter per kilo per minute improvement with no worsening of NYHA class. Individuals could achieve either of these two to be considered as responders. In addition, a host of secondary endpoints were off-controlled and included change from baseline in peak exercise outflow gradient, peak VO2 consumption, the proportion of patients with one or more NYHA class reduction, and importantly, patient-reported outcomes designed to capture a more global well-being of the patients with this chronic disease, including the Kansas City Cardiomyopathy Questionnaire Clinical Summary, and a specifically developed and validated score called HCM Symptom Questionnaire Shortness of Breath subscore. Overall, 251 patients were enrolled in the study, and this makes Explorer the largest randomized controlled trial ever performed in hypertrophic cardiomyopathy. Baseline features were balanced between groups, except for a smaller proportion of patients who were male and had a history of atrial fibrillation in the mavacamten group. 92% of patients were allowed to continue on their background therapy with beta blocker or calcium antagonist. Most patients were in class 2, although about a quarter were severely symptomatic in class 3. If you look at the baseline echo parameters, these were also well matched between groups, with a starting ejection fraction of 74% as a testimony to the hypercontractile state in these patients, and elevated post-exercise gradients ranging, averaging approximately 85 millimeters of mercury, so severely obstructive. And now, let me review the top-line results of Explore-HCM with you. At the end of the 30 weeks of treatment, nearly 37% of patients on mavacamten achieved the primary endpoint, which represents a doubling of the response seen in the placebo group. And this was highly statistically significant. In addition, 20% of patients on mavacamten met both at least the 3 millimeters per kilo per minute increase in peak VO2 and at least the 1 NYHA class improvement versus only 7.8% of those on placebo. Mavacamten was associated with significant improvement in all secondary endpoints compared with placebo, including greater reduction in post-exercise alpha gradient of 36 millimeters of mercury and a greater increase in peak VO2 by 1.4 milliliter per kilo per minute versus placebo. Notably, 65% of mavacamten patients demonstrated an improvement of 1 NYHA class or more, representing twice those on placebo. Furthermore, there was marked improvement in both patient-reported outcomes, with a notable difference of 9 points for KCCQ compared to placebo. These graphs show the changes in outflow gradients and systolic ejection fraction and systolic function over time. Placebo is shown in red and mavacamten is shown in blue. In addition to the mentioned reduction, the important reduction in post-exercise gradients, patients on mavacamten had a dramatic and sustained reduction in both resting and Valsalva gradients, which are shown in the two bottom panels. At any given time during treatment, these gradients fell below the dashed horizontal line, which is the threshold for invasive septal reduction therapies of 50 millimeters of mercury. But importantly, most of these patients went well below the 30 millimeter threshold, which actually defines obstruction. So they had a complete relief of obstruction at rest and during Valsalva. And in parallel to these dramatic hemodynamic effects, the reduction required in ejection fraction to deliver this result was very small. So the reduction in left ventricular ejection fraction is shown at the upper right panel. And as you can see, there was only a 3.9% reduction in ejection fraction in mavacamten treated patients as compared to placebo. If we look specifically at the post-exercise left ventricular outflow gradient, which is the highest ranked secondary endpoint and likely the most clinically meaningful for HCM patients and clinicians, there was very consistent benefit across all the pre-specified subgroups, including patients with different genetic status. And this suggests that the effects of mavacamten is largely independent of genotype. In addition, we assessed a number of pre-specified exploratory endpoints. Let me just draw your attention to the bottom line here. Complete response was defined in the study as complete abolition of gradients, so all gradients, including exercise gradients below 30 millimeters of mercury, associated with total relief of symptoms, so NYHA class 1. This status was achieved by 27.4% of patients on mavacamten versus less than 1% on placebo. This is comparable to a best-case scenario following successful invasive septal reduction therapy, such as surgical myectomy, for example. And again, in parallel with these hemodynamic changes, we observed important, marked, and sustained reductions in biomarkers such as